and move into some background information on the topic, discuss 3 research studies about Parkinson's disease, share next steps with treatment, and then with time for audience questions. My personal interest in Parkinson's comes from my grandpa. He lived with the disease for about 10 years, and I just wanted to learn more about how nutrition might impact the treatment. Parkinson's disease is the second most common neurodegenerative disease, and neurodegenerative simply means that it causes the death of neurons in the brain. It is the most common movement disorder. It's chronic and progressive, which means that over time the symptoms of the disease become more apparent, and the dosage of medication has to increase to account for the increase in symptoms. Neurons in the brain gradually break down or die, and this causes a decrease in dopamine levels, and that leads to the abnormal brain activity, and the abnormal brain activity is what leads to the Parkinson's disease symptoms. Common symptoms. This slide lists the most common symptoms, but they vary based on each individual case of Parkinson's disease, so one patient may look very different from the next one. Tremors are rhythmic shaking, and they occur at rest. They typically start on one side of the body and then gradually move to the other side as the disease progresses. Bradykinesia is slowness of movement, and that can lead to problems with fine motor coordination and things like buttoning a shirt. Postural instability also occurs. It can be a stooped posture, which leads to patients getting off balance easier, falling. Impaired gait, they can shuffle their feet or just kind of slow, rapid, quick steps that can make it difficult to move, as well as altered speech. And that can lead to the words kind of being crowded together or slowed down. It can also impair their ability to swallow, which does impact their nutritional status, as well as the tremors can make it more difficult for them to feed themselves. And the tremors, stiffness or rigidity of muscles, and bradykinesia are considered the 3 core motor symptoms of Parkinson's disease. Disease diagnosis. There is no specific clinical test to diagnose Parkinson's, but trained neurologists look for at least 2 of the 3 core motor symptoms that I just discussed on the past slide. You can confirm the diagnosis of Parkinson's with medication, so taking carbidopa-levodopa, the most common form. And if patients take medication and their symptoms go away, then you know that then the doctors know they have Parkinson's. Brain imaging can also be used to rule out other diseases, but it's not used with each patient. Treatment. There is no cure for Parkinson's disease, but individuals are able to live with it for several years. Medication can help control the symptoms, but it won't slow the progression of the disease. And as I said before, the dosage of the medication will continually have to increase to mediate those symptoms. Surgery can be recommended for advanced cases in the form of deep brain stimulation, but there are side effects that go along with this, so it's not always recommended. And again, that will only aid in treatment and symptom relief. It won't slow the progression. Common medications. The slide lists 2 most common, carbidopa-levodopa and the dopamine agonist. So carbidopa-levodopa is the most common form. Levodopa is the precursor of dopamine, and it's given in this form because it crosses the blood-brain barrier. Carbidopa is used to prevent levodopa breakdown in the blood, which is why they're given in conjunction with one another. Dopamine agonists mimic dopamine in the brain, and they can be used along with the carbidopa-levodopa. They have a longer, they are longer lasting than carbidopa-levodopa, but they're not as effective, but they can kind of smooth over off periods, and the off times are when those symptoms are returning or the patients just aren't having the relief from their medication. So the dopamine agonist can be used so when the carbidopa-levodopa wears off, it's not such a drastic drop-off. The carbidopa-levodopa protein effect is a concern just for a subset of Parkinson's disease patients. And it occurs when large neutral amino acids from dietary protein are favored over the medication for absorption. And in this diagram, you can see the purple transporters on the intestinal membrane. They are the same for both the medication as well as the amino acids. So if you have a lot of amino acids in the body, in the intestine, they're competing for those transporters along with the medication, so less is being absorbed into the blood. Research has suggested a couple diets to help with Parkinson's disease, and both related to protein, so the protein restricted and protein redistribution diets. The protein restricted diet does limit the amount of protein that individuals consume on a given day, but there has been found to be concern for malnutrition with this if they're not meeting their daily needs of protein. Protein redistribution diet does not limit the amount of protein, but it just kind of redistributes it to the evening meal because it's thought that motor coordination and motor movement is less important at this time of the day. Now to get into the research studies. So my first study I looked at is entitled Dietary Habits and Neurological Features of Parkinson's Disease Patients, Implications for Practice. The objective was to investigate the association between Parkinson's disease patients' diets and their neurological features. So here is some terminology that I will use throughout this study and some through the rest of my presentation. So PD is Parkinson's disease, L-DOPA is levodopa, FFQ is food frequency questionnaire, and TDEE is total daily energy expenditure. The study design, this was a cross-sectional case control study. There was a total of 600 Parkinson's disease patients. They were all diagnosed with idiopathic Parkinson's disease, and idiopathic just means that the cause of the disease is unknown, and this is the most common form of Parkinson's. They were given a suggested protein redistribution diet, which was just part of the treatment at the Parkinson's Institute in Milan, Italy, where all the patients were from, but only about 50% were adhering to this diet during the study. And the controls were matched one-to-one by gender, age, physical activity level, and geographical area. And the study did look at a variety of data for assessment. They looked at anthropometric data. They used the 66-item food frequency questionnaire, and this was detailing food and drink that they consumed within the past 12 months. It also looked at bowel habits as well as Parkinson's disease features or the symptoms they were experiencing. Looking at the results, so this table shows the energy balance and body weight of the participants. So the left-hand column is the Parkinson's disease patients, the right are the controls, and over here on the far right-hand side is the p-value, so you can see the differences between these two groups was found to be statistically significant for all of these factors. So body weight, BMI, and total daily energy expenditure was lower among the Parkinson's disease patients compared to the controls. But it's interesting to see that their calorie intake was actually higher than the controls. So that's showing that even though they're consuming more calories, they're not having that increase in body weight or BMI. And this could be due to changes in their body, how their body is using energy or the increased demands, as well as the motor complications can increase their calorie needs. The study did suggest a hypercaloric nutritional supplement to aid in reducing the body weight and BMI decreases for the patients, but this is unknown if it would actually help because they currently are consuming more calories, but they're still not seeing that benefit. Looking at disease progression, so BMI was found to be inversely associated with disease duration and severity. So this table compares patients who are less than 5 years with the disease, 6 to 11 years, and greater than 12 years. And again, the differences were statistically significant for these factors. So you can see that body weight and BMI continued to trend downward as the disease progressed, and the calorie intake actually continued to increase. But again, it's just not seeing the benefit with their weight gain. So there was a correlation between greater protein intake and L-DOPA dosage as well as adverse side effects. So the protein intake increased slightly as the Parkinson's disease patient's disease progressed. This may be due to just taking in more calories, as I discussed that they were consuming more. It was increased, which also shows the levodopa dosage had to increase, and it could be in part to that increase in protein as well as just the disease progressing. The time in off state or when those symptoms were showing, as well as dyskinesia also increased, and those two the off-stated dyskinesia are reported using the Unified Parkinson's Disease Rating Scale. So that's where those numbers are coming from. Constipation also increased as the disease progressed, and this can be due to an increase in levodopa dosage, with constipation being a side effect, as well as as the disease progressed, the patients were consuming less water, which can lead to constipation. The patients adhering to the protein redistribution diet did have higher body weights and lower levodopa dosage, as the study did find. In conclusion, nutritional care is an important element of Parkinson's disease treatment. There should be an emphasis on adequate calorie intake and adequate protein, though not excessive protein, to reduce the risk of malnutrition while maximizing the effect of the medication. The strengths of this study: the controls were closely matched to the study subjects. It was a fairly large sample size of 600 Parkinson's disease patients, and the authors didn't have any competing interests. The limitations: it was a cross-sectional study design. It would have been more beneficial to look at patients more than just one point in time to look at them more in detail. All patients were from the same movement disorder clinic. That can lead to question if they were truly a representative sample of all Parkinson's disease patients. And lastly, there was 66 items on the food frequency questionnaire, and when you consider everything that an individual could eat or drink in a given year, that may not truly reflect all the options they had, so the results may have been impacted. I did give this an EAL rating of positive. The second study is entitled Motor Fluctuations Due to Interaction Between Dietary Protein and Levodopa in Parkinson's Disease. So the objective was to determine which PD patients are more likely to experience motor fluctuations related to protein interaction with L-DOPA. So some more terminology: PIL, or pill, is protein interaction with levodopa, and I will use that several times throughout the study. FOG is just an abbreviation of freezing of gait, and then dyskinesia and orthostasis are both abbreviated in one of the graphs I use. So dyskinesia is involuntary muscle movement, and orthostasis is lightheadedness upon standing. This was a retrospective cohort study. There was a total of 1,037 Parkinson's disease patients, and they were seen at the Columbia University Movement Disorder Center. Their clinical records were analyzed between 2000 and 2012. They were all diagnosed with idiopathic Parkinson's disease based on the UK Rhinebank criteria. And the study determined if pill, or again that's the protein interaction with levodopa, they considered pill motor fluctuations to be occurring when these symptoms, or when these were occurring, so longer time to L-DOPA effectiveness, reduced benefit or duration of benefit, dose failures, and then earlier wearing off from a previously effective levodopa dosage. Looking at the results, so 5.9% of the patients in the study were found to have motor fluctuations related to protein intake. So the first graph over here, with all the graphs, so the first bar is the pill patients, and then the next one is comparing to the all non-pill patients. So the other bars are just breaking down the non-pill patients further, but I'll just be looking at those first two bars. So the age at motor onset was found to be the difference was statistically significant between the pill and non-pill individuals, and it was lower among those experiencing the protein interaction with levodopa. And this goes hand in hand with the next graph, the duration of the disease. So the pill patients had a longer disease duration, which just kind of goes hand in hand with being younger at the motor onset, and as well as the years on levodopa. So they had more years on the medication. The maximal daily levodopa dosage was also higher among the pill patients compared to the non-pill patients. So they're having to take more medication to relieve their Parkinson's disease symptoms. And it's interesting to see the study looked at patients with a family history of Parkinson's disease, and those in the pill group did have a statistically significant difference. It was higher with a family history of Parkinson's disease. Looking at some more of the symptoms. So motor symptoms were more severe in the patients experiencing pill. So the motor fluctuations fluctuations, freezing of gait, and dyskinesia, the first three areas of the graph, were all higher in the pill patients compared to non-pill patients. And so these motor symptoms were more apparent. But the nausea, orthostasis, and hallucinations, these non-motor symptoms, were not found to be statistically significant between the pill and non-pill. So the study found that 20 of the patients reported making dietary modifications, and that was a variety of things, either decreasing total protein, or having smaller frequent meals, or redistributing it to the evening meal. 60% of these patients had a weight loss, or reported a weight loss when they made those dietary modifications. So it's important to consider if the risks outweigh the benefit, or what each individual needs. In conclusion, there are protein interactions with levodopa. They most often occur in patients with an earlier disease onset and those with a family history of Parkinson's disease. The symptoms do get worse, or the motor symptoms are worse among the pill patients compared to the non-pill patients. The dietary modifications should not be recommended to all individuals because there is that risk for malnutrition, but looking at all factors and weight loss and continuing to monitor that as the medication changes is important. The analysis, the strengths, the study was critical of previous findings. It didn't just accept a protein restricted or protein redistributed diet. It looked at if it was truly beneficial. Only patients reporting motor fluctuations related to protein intake were included in the pill group, and so motor fluctuations can occur, or a variable response to the medication can occur when individuals either had a large meal or other factors. So if they didn't directly report that they had a high protein meal and then that translated into impaired medication effectiveness, those were the only ones included in the pill group. The authors did not have any competing interests. It was a retrospective study design, and this is a concern for bias, that a prospective study is always better. All participants were from the same movement disorder center, and again, this leads to questions similar to the first study if they were truly a representative sample of the entire Parkinson's disease population. It is fairly subjective data based on patient recall as well as consistency of physician questioning. So if the physician asked a question one way to one patient and then a different way to another patient, it could have impacted how the questions were answered and as well as their results. I did give this study a neutral rating. The final study I looked at is entitled Amino Acid Supplementation in L-DOPA-Treated Parkinson's Disease Patients. The objective was to evaluate the effect amino acid supplementation has on nutritional status and motor performance of PD patients taking L-DOPA, along with a suggested protein-restricted diet. So some terminology, RCT is randomized controlled trial, and AA is an abbreviation for amino acids. So the methods. This was a prospective randomized controlled trial. The participants were randomly assigned to either the intervention or the placebo group. 22 were enrolled in the study, but only 14 were actually analyzed. 5 dropped out of the intervention group due to potential negative side effects of the amino acid supplementation, as well as low adherence or comorbidities that showed up. And 3 dropped out of the the placebo group. They were diagnosed based on the UK PD Brian Bank criteria. They had to be on levodopa therapy for at least 2 years when the study began. Patients were all seen at a movement disorder center in Italy, and the intervention lasted a total of 6 months. So this table shows the participants at baseline. So the left-hand column is the intervention group, the right-hand column is the placebo group, and the p-values are shown over here. So you can see the differences for all of these factors was not found to be statistically significant between the two groups. So that is positive that they're a good representative sample size to compare to one another. The intervention group, they were given 16 grams of amino acids, of free essential water-soluble amino acids for 6 months each day. They received 2 bags of the amino acids 60 minutes after dinner and 60 minutes after lunch. 4 grams of amino acids were given per bag. The oral supplement was consumed at least 60 minutes before the next levodopa dosage to minimize the risk for that protein effect. Each supplement administration corresponded to 28 grams of dietary protein. And the participants in the control group received placebo according to the same regimen, so they didn't know which group they were in. Results. So the assessments were taken at baseline, when the study began, 3 months, and then at the conclusion at 6 months. This table looks at average daily off time. So that's when those symptoms were returning or when they weren't having the relief with the medication. So the intervention group and the placebo group the difference was not statistically significant. So even though they were getting the amino acid supplementation, the intervention group did not experience more off periods, which is beneficial to see. On the other hand, the insulin sensitivity was statistically significant between the two groups, and the insulin sensitivity decrease was lower in the intervention group compared to the placebo group. And insulin resistance is something that often occurs with Parkinson's disease patients, so even though both groups did have a decrease, it's beneficial to see that it didn't go down. The sensitivity did not go down as much in the intervention group. Looking at the levodopa dosage, so in the left 3 bars are the intervention group, so this is at baseline, 3 months and 6 months, and same with the placebo group over here. This shows that the dosage of levodopa did not have to increase significantly over the course of the intervention, which is great to see that even though they were taking the supplement, the amino acids, they didn't have to take more medication. Oxidative stress. Oxidative stress is something that often leads to cellular dysfunction among Parkinson's disease patients. So on the left hand, this is the intervention group compared to the placebo. Looking at the average from 3 months to 6 months and comparing that to baseline, the individuals in the intervention group had a decrease in the oxidative stress compared to the placebo group. They had an increase. In conclusion, the amino acid supplementation was not found to have detrimental neurological or pharmacological effects in protein-restricted PD patients who are chronically treated with L-DOPA. It may reduce the risk of malnutrition because they are getting the higher protein dosage, which is important. There was no significant increase in off periods or levodopa dosage that they had to take in order to relieve their symptoms. The strength of this study was a randomized controlled study design. The participants in the intervention and control groups were very similar at baseline, which means they could be compared to one another well. The limitations, it was quite a small sample size. There was only a total of 14 and 7 in each group. And there was a high attrition rate, so kind of several dropouts as well. It was a fairly short follow-up period of 6 months, so it's unknown for sure if this was enough time to determine the effectiveness of the supplementation. I did give this a positive study rating. Looking at next steps. So the implications for practice for dietitians. Parkinson's disease symptoms do impact nutritional status, and I discussed that throughout my presentation. There are higher calorie needs that come about just how their body burns calories and just that they're losing the weight easily. They have difficulty eating caused by some of the symptoms of Parkinson's disease, as well as the protein effect that occurs in a subset of Parkinson's disease patients. It's important to work with the entire team to determine the appropriate diet for each individual patient, because the symptoms range, the amount of medication ranges. It's important to determine with everyone what is the best approach. And moving forward for action for Parkinson's disease treatment, calorie and protein recommendations must be individualized based on each patient. The risk of malnutrition should be addressed and continually monitored as the disease progresses and as the medication changes. And there does appear to be, the amino acid supplementation does appear to have benefits but there should be further research in this area to determine the true effectiveness. This is